Hey guys, this is FixerMed. Welcome back to my ECG Skills Builder Workshop, where I will be covering all of the fundamental knowledge and skills you will need to read and interpret an ECG in a quick and effective manner. This will be part 16 of my multi-part video series of doing so. Today, we will continue looking at some more ECG abnormalities. Without any further delay, let's go ahead and get started on today's content. Let's look at Wolff-Parkinson-White syndrome. Key features: PR interval under 0.12 seconds, a delta wave QRS duration of 0.12 seconds or more, a normal P wave axis. Let's look at acute pulmonary embolus, small pulmonary embolus. If the blood clot is small, the electrocardiogram, ECG, often appears normal. The only noticeable change might be a faster than normal heart rate, known as sinus tachycardia. Large pulmonary embolus with artery obstruction. A larger blood clot can cause a blockage in the pulmonary arteries, leading to strain on the right ventricle of the heart. This strain can manifest on the ECG with specific changes, including S wave in lead. 1. This is a downward deflection after the QRS complex. Q wave in lead. 3. This is a downward deflection before the R wave. T wave inversion in lead. 3. The T wave, normally upright, appears flipped downwards. S1, Q3, T3 pattern. This refers to the combination of the above findings, forming a specific pattern recognizable for pulmonary embolism. Let's look at ECG findings in various conditions. Chronic obstructive pulmonary disease, COPD, P pulmonale low amplitude QRS complexes, poor R wave progression, hypertrophic, cardiomyopathy, left ventricular hypertrophy, left atrial enlargement, abnormal inferior and/or lateral Q waves, bizarre QRS complexes mimicking pre-excitation or bundle branch block dilated cardiomyopathy, left bundle branch block, left atrial enlargement, left ventricular hypertrophy, abnormal Q waves in leads V1 to V4 arrhythmias, supraventricular and ventricular. Let's continue to look at more ECG findings in various conditions. Restrictive cardiomyopathy, low voltage QRS complexes. The electrical signals generated by the heart appear smaller than normal. Conduction disturbances. Issues with the heart's electrical conduction system can lead to abnormalities in the heart rhythm. Arrhythmias, supraventricular arrhythmias. These abnormal heart rhythms originate in the upper chambers of the heart, atria. Examples include atrial fibrillation or atrial flutter. Ventricular arrhythmias. These abnormal heart rhythms originate in the lower chambers of the heart, ventricles. Examples include ventricular tachycardia or premature ventricular contractions. Let's continue to look at more ECG findings in various conditions. Hypothermia. Tremor artifact. Shivering from the cold can create electrical interference on the ECG, making it difficult to interpret. Atrial fibrillation with rapid ventricular rate. This is an irregular, often fast heart rhythm originating in the atria. J waves, also known as Osborn waves. These are small deflections seen at the junction of the QRS complex and ST segment, characteristic of hypothermia. Bradycardias. The heart rate becomes significantly slower than normal, particularly pulseless electrical activity, PEA, where electrical activity is present but doesn't produce a pulse. Prolongation of intervals. The PR interval, QRS complex, and QT interval may all be longer than usual. Ventricular arrhythmias. These dangerous heart rhythm disturbances can include premature ventricular contractions, ventricular tachycardia, and ventricular fibrillation. Asystole. This represents the complete absence of electrical activity in the heart, signifying cardiac arrest. Thyrotoxicosis, most common. Sinus tachycardia, increased QRS voltage. Atrial fibrillation, less common. Supraventricular arrhythmias, PACs, SVT, MAT, atrial flutter. Nonspecific ST and T wave changes, ventricular extrasystoles. Hypothyroidism, most common, sinus bradycardia, prolonged QT interval, flat or inverted T waves, less common, heart block, low QRS voltages. Intraventricular conduction defects, ventricular extrasystoles. All right, guys, now that we have covered all of the content, let's go ahead and take a look at some questions to review the knowledge you have gained so far. A patient presents with muscle weakness and an abnormal ECG. The ECG shows tall peak T waves and a widened QRS complex. Which of the following electrolyte imbalances is most likely responsible for these findings? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The ECG findings of tall peak T waves and a widened QRS complex are classic signs of hyperkalemia. This electrolyte imbalance affects the electrical conduction system of the heart, leading to these characteristic changes. As potassium levels rise, the resting membrane potential of cardiac cells becomes less negative, causing earlier repolarization and the peaked T waves. Further increases in potassium can slow conduction and widen the QRS complex, eventually leading to severe arrhythmias if left untreated. Therefore, the correct answer is B, hyperkalemia. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. Hypokalemia. This typically causes flattened T waves, prominent U waves, and ST depression, which are opposite to the findings in the question. C. Hypernatremia. While it can cause neurological symptoms, it does not typically produce specific ECG changes like those described. D. Hypocalcemia. This can prolong the QT interval but does not cause peaked T waves or QRS widening. E. Hypercalcemia. This may shorten the QT interval, but does not cause the specific ECG changes seen in hyperkalemia. All right, now that we have covered this question, let's move on to look at the next question. A patient arrives at the emergency department with severe chest pain. Their ECG shows ST segment elevation in leads 2, 3, and AVF. Where's the most likely location of the myocardial injury? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. ST segment elevation indicates acute myocardial injury, and the location of the elevation on the ECG corresponds to the area of the heart affected. Leads 2, 3, and AVF specifically look at the electrical activity of the inferior wall of the left ventricle. Therefore, ST elevation in these leads suggests that the patient is experiencing an acute myocardial infarction, heart attack, affecting the inferior wall. Therefore, the correct answer is C, inferior wall of the left ventricle. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A, lateral wall of the left ventricle. This would be indicated by ST elevation in leads 1, AVL, V5, and V6. B, anterior wall of the left ventricle. This would be indicated by ST elevation in leads V1 to V4. D, interventricular septum. This may show ST elevation in leads V1 and V2, but typically in conjunction with other leads depending on the extent of involvement. E, right ventricle. This is less common and may show ST elevation in right-sided leads like V3R and V4R, but typically in conjunction with inferior wall involvement. All right, now that we have covered this question, let's move on to look at the next question. A patient with stable angina experiences chest pain during exertion. Which of the following ECG findings is most consistent with their condition? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. Stable angina is caused by a temporary reduction in blood flow to the heart muscle, leading to myocardial ischemia. This ischemia typically manifests on the ECG as ST segment depression, especially during episodes of chest pain. The depression reflects the imbalance between oxygen supply and demand in the heart muscle. Therefore, the correct answer is B, ST segment depression. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. ST segment elevation. This is more indicative of acute myocardial injury, as seen in unstable angina or myocardial infarction. C. Peaked T waves. These are typically associated with hyperkalemia, not ischemia. D. Prolonged QT interval. This can be caused by various factors, including certain medications and electrolyte imbalances, but is not a typical finding in stable angina. E. Prominent U waves. These are often seen in hypokalemia, not ischemia. All right, guys, that is all I have for this video today. If you like this type of content, be sure to leave a like and subscribe for more content like this in the future. Be sure to leave any questions, comments, or concerns down in the comment section below. This is FixerMed signing off. Be sure to have a great day, everyone, and good luck studying as always. Goodbye.